speaker is for today is Jess Eccles.
Hello, can you start my video, please?
Jess, can you hear me?
I can hear you, but
All right.
but it won't let me start my video or share screen.
Okay. Can we stop sharing screen of previous participants?
Yeah, can you try now, Jess?
Okay, so I'm just give me 1 second. It's gone. PowerPoint has gone funny at the last minute.
All right, so let me introduce our next speaker, which is Dr. Jess Eccles. She's trained in medicine at University Cambridge, at the University of Oxford, and undertook combined clinical academic training in liaison psychiatry and at Brighton and Sussex Medical School. As an MRC clinic research training fellow, she completed her PhD in relationship between joint hypermobility, autonomic dysfunction, and psychiatry symptoms, and is now a clinical senior lecturer. Her interests are in the body-brain relationships in musculoskeletal conditions, particularly variant connective tissues, including anxiety, ADHD, autism, brain fog, and pain and fatigue. So over to you, Dr. Jess.
Can you let me start my video so that people can see me talk? It says the host has stopped it. Okay, start my video. There we go. Hello, everyone. My name is Jess Eccles. I am, if you want to follow me on Twitter, I'm at Bendy Brain. I'm very privileged to have a dual job in which I spend 2 days in an adult neurodevelopmental service in Sussex and 3 days at Brighton and Sussex Medical School doing research about brain-body conditions. Our adult neurodevelopmental service is for non-learning disabled adults. And we have a combined autism, ADHD, and Tourette syndrome pathway. We have just set up within our service, which I'm going to show you some of the research that led to, something called the Neurodivergent Brain Body Research Clinic. So I'm just going to try and move the slides forward. So I really like this graphic from the Guardian newspaper that I saw sometime last year now, and this is in response to a book published by Ed Bullmore. The big idea: should we drop the distinction between mental and physical health? And I really think that we should. What I want to try and talk to you today is about how autism isn't just about different neurotypes. It could be about differences in the body as well. So the current false dichotomy between brain and body, or mental and physical health, really holds back research and perpetuates stigma. So what I'm going to talk about briefly, which I don't think I'll need to because of the language thinkings yesterday and everything, is, but thinking about neurodivergence broadly, building on what Connor said in terms of how we've been through such a sea change in thinking since I graduated from medical school in 2006. What is the relationship to this concept of hypermobility? Why is this important? And what does it mean for the future? So this is just a graphic. I think it's actually been updated from Genius Within to demonstrate various neurodivergent conditions, including autism, ADHD, Tourette, dyslexia, dyspraxia, dyscalculia. And in my clinical experience, we definitely see characteristics of each in lots of individuals, and also really to put through the idea that it is possible to work in a neurodiversity affirmative way. So recognizing both the strengths and challenges that come with having a different way of thinking and being in the world, and that evolution has essentially created a variety of thinkers, and we need this to bring a richness to humanity. Okay, so this just summarizes in some ways what Connor was saying, that when I was at medical school, I was taught that autism was 9 times more common in boys rather than girls, again, thinking that it was really a condition of childhood. We know that there are so many non-stereotypical autistic presentations that get missed. This is women, non-trans, non-binary, trans individuals, people of color. We know that a lot of autistic people we see actually have heightened empathy or differences in empathy, but the empathy and theory of mind are not inherently disordered, perhaps different. Neurodivergent or neurodivergent communication is often very successful, and autistic people can have friends, they can make eye contact, but there are subtle differences in social communication. And what I'm really learning is that co-occurrence is the norm rather than the exception, be that for other neurodevelopmental conditions, some mental health conditions, and certain physical health issues, which is what I'm going to talk to you about today. And really the learning journey that I've been on is that the language that we use is important. It's not possible to get everything right all of the time, but talking, just using the word co-occurring rather than comorbid, I think can make a big difference to how things land in the world and how people feel about themselves. So language is important, but constantly changing. Now, this was an article that a colleague pointed me towards in lockdown. This was published in 2020, and it looked at teachers who often gatekeep or are important gatekeepers in autism assessment in young people. And essentially, if you put the same vignette with a girl's name on it rather than a boy's name, they're less likely to be referred for onward assessment. These things really have to change. This is in school teachers, and I don't want to malign school teachers, but I think this is across the board how much work there is to do in order to challenge stereotypes. So what is the issue? What am I kind of interested in to talk to you about today? So we know from work that there are a variety of physical health co-occurrences in autism. And Mary Doherty, organising this conference today, she and my colleagues, she amongst other colleagues at Brighton and Sussex Medical School and others, produced this wonderful paper illustrating barriers to healthcare and self-reported adverse outcomes for autistic adults. Our health service is not doing enough for neurodivergent people in terms of facilitating appropriate access to healthcare and personalising healthcare for neurodivergent individuals. So for me, as I was introduced, it mentioned about this combined clinical academic career. And really my work at Brighton and Sussex Medical School, which I started in 2009, has been an evolving light bulb moment. I'm not sure if a light bulb moment evolves or it's just a series of light bulbs. But when I came to Brighton and Sussex Medical School, I started working on this topic. Now, I don't, obviously I can't really interact with the audience, but if you could just put in the chat, yes, if you know what this is, please do so. And then I can see the numbers of the chat go up. Okay, this is good. This is good. Quite a few numbers going up. Is it going to be that the whole chat, the whole 300 and something people know? Because if that was the case, I think my work is done and I could go home. No, not quite. We're stabilizing. But this is a lot more than people before. So this is a depiction of something called joint hypermobility, and it's one of the ways of either assessing for it or looking for it. And as you can see, there are things like being able to bend your fingers upwards. And a common thing is for children and young people to sit in this W position, or to be able to put your hands behind your back in a prayer sort of pose. But really, hypermobility is a bit of a misnomer, and I'm going to talk about it, why it's important not to just focus on flexible joints. So hypermobility is far more than just having flexible joints. We have to think, why do people have flexible joints? And that's because of differences in underlying connective tissue, the kind of cling film that holds us all together. And actually having flexible joints can be relatively common. And like elements of neurodivergence can be advantageous. Certain piano pieces can only be played by hypermobile fingers. Musicians, ballet dancers, hypermobility is an important part of their work, but it's also linked to a variety of medical issues because of going back to this connective tissue issue. And these issues cross systems and involve both the body and the brain. And unfortunately, hypermobility is mired by a variety of classification, screening tools and diagnostic terms, which means that people, doctors, are quite confused. Is it EDS? Is it HSD? Is it JHS? Is it GJH? There are so many different terms. So you can have hypermobility, and that's just generalized joint hypermobility, or you can have medical symptoms alongside, and that's symptomatic joint hypermobility, commonly called hypermobility spectrum disorder, or in some cases hypermobile EDS. But it really, teasing things apart and even doing reliable research is very hard because of all of the different tools. So this is actually a relatively old slide, but I just want to show you how many things are associated with hypermobility that neurodivergent people may experience. So, I'm going to get to the link between hypermobility and neurodivergence in a minute, but things like gastro issues, reflux, irritable bowel, inflammatory bowel, gastritis, abdominal pain, Raynaud's phenomenon, irritable bladder, strabismus, that's a squint, myopia, TMJ dysfunction, dental pains, dyspraxia, proprioceptive dysfunction, fatigue, anxiety, and then sensory sensitivities and pain. So I understand today is mainly a professionals day, so I have included just a brief slide that teaches you how to look for symptomatic hypermobility, but essentially it's to do with a combination of presence of joint hypermobility and a number of other connective tissue feature signs. And this diagnostic categories are changing all of the time. The 2017 criteria, very subtly different to the 2000 criteria. But interestingly, the self-report questionnaire, can you now or could you ever place your hands flat on the floor without bending your knees? Can you now or could you ever bend your thumb to touch your forearm? As a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? As a child or teenager, did your shoulder or kneecap dislocate on more than one occasion, or do you consider yourself double jointed? A score of 2 or more is got good predictive value for picking up hypermobility, but it's so much more than this. Recurrent multiple abdominal hernias, arachnodactyly, that's having thin, narrow wrists, mitral valve issues, stretch marks, hernias, soft, stretchy skin, pain, and like autism, ADHD, and other neurodivergences, tends to run in families. So I got into this work through anxiety because there was an association between anxiety and hypermobility. 70% of people with panic were hypermobile compared to about 20% who did not have panic. And interestingly, at the time, it seemed a little silly, well, not silly, but a bit Christmas BMJ. There were these articles about joint hypermobility, anxiety sensitivity, and increased chocolate consumption, increased tobacco consumption and alcohol use. And it was purported, is this a way to cope with anxiety? And now, having gone through this journey, I'm wondering, is this a way of self-medicating or ADHD? Is it a way of trying to handle some of the social communication challenges that neurodivergent people face. It's a whole new frontier of thinking, really. So I spent my PhD trying to work out how you get from having flexible joints to having a panic attack. And I'm not going to go into too much detail because it's not strictly neurodivergence, but we know that so many neurodivergent people have co-occurring anxiety, and anxiety can be a really impactful symptom. So we found that people who are hypermobile had slightly different sized brains in a part of the brain called the amygdala, which is responsible for fear and emotion processing. Now, is this cause or effect? We have no idea, but it points to a biological reason why hypermobile people may be overrepresented in anxiety groups. We're actually just wrapping up an analysis now on a sample of about 150 people, anxiety, no anxiety, hypermobility, no hypermobility. So we should be able to answer this question better, but what we really need is a longitudinal study. So when I was at medical school, I had to write an essay. Do we run from the bear because we're afraid, or are we afraid because we run? To be honest, I never thought I quite understood the question. But what we know from work that colleagues and others have been doing, William James and Sutter and Singer, is that our autonomic nervous system, our heart rates, our breathing rates, they provide a context for our emotional interpretation. So if you show people pictures when you think that your heart is beating faster than it actually is, you will rate them as more intense than when your heart is beating normally. And in hypermobility, there is this thing. Well, in hypermobility, about 80% of people with symptomatic hypermobility experience postural tachycardia syndrome, a physical co-occurrence where you get an increase in heart rate from up to 30 beats per minute. And this can also happen, so you get palpitations, dizzy, lightheaded, feeling of doom. This can happen after a large meal and also after having a hot shower. And it is manageable. So it's a really important co-occurrence to identify and get to grips with. And what we, and I'm going to show you in a minute in a model, that we think that this overactivation of the flight or fright nervous system, which is to do with the floppy connective tissue potentially causing cardiovascular changes, which mean when you go from lying to standing, your blood pools in the feet and you have to raise your heart rate in order to maintain your cardiac output, or you may have differences in your nervous system and small fiber neuropathies and things that are leading to this phenomenon. We recently published on how hypermobility in adolescents predicted common mental health problems at 18, so anxiety and depression. And we've published on how the link between hypermobility and autonomic symptoms is actually common and impactful in, well, this was 400 community mental health patients. So they didn't know they were hypermobile, but the hypermobile people have more physical health concerns. So we found, and this has actually just been submitted for publication yesterday or the day before, we found that the autonomic system seems to be integral in the relationship between hypermobility and anxiety. And this led to us developing a non-drug interoceptive treatment for people living with anxiety and hypermobility that was adapted from a treatment, an intervention for anxiety in autistic adults, AD. Anyway, back to those brains at the beginning. When we looked at those brains, we found there were differences in area of the brain involved in where we are in space, and the volume got smaller the greater the number of hypermobile joints. There was also differences in temporal lobe that were similar to those observed in autism and ADHD. So what are the commonalities between hypermobility and neurodivergent conditions? Well, these abnormalities of the flight or fright nervous system have been reported. Pain, dyspraxia, anxiety, all commonly overlap. This is the brain imaging findings of the proprioceptive differences. And whilst we were thinking about hypermobility and neurodevelopmental conditions and actually conducting a study, we were picked to the post by the whole population of Sweden, where they where they looked in their health registry and found that if you had a symptomatic hypermobility diagnosis, now, as Connor says, diagnostic delay is huge. So there is actually, it's quite tricky to get an EDS diagnosis. You were 7 times more likely to have an autism diagnosis. Also, imagine how likely it is that you might actually have a diagnosis. So this is perhaps the tip of the iceberg. The same with ADHD, nearly 6 times more likely to have an ADHD diagnosis if you had symptomatic hypermobility. And here are some other papers linking ADHD and autism to hypermobility and pain. We published on connecting brain and body, transdiagnostic relevance of connective tissue variants to neuropsychiatric symptom expression. So this idea that hypermobility and neuropsychiatric phenomenon are really across the body and across psychiatric phenomena and neurodevelopmental conditions. So what did we do? We published this article last year. Joint hypermobility links neurodivergence to dysautonomia and pain. Now, this it doesn't sound particularly controversial, but this was quite a bold move to use the word neurodivergence in a biomedical article. And there were a couple of reasons for that. One is we wanted to use non-ableist language. And secondly, I feel a lot of research is let down by looking at ADHD or autism or Tourette syndrome in isolation. You don't know how many people have co-occurring other neurodivergent conditions. So we looked across the neurodivergent group, and we specifically looked for the relationship with physical health concerns. And what we found was that if you were hypermobile, we compared our clinic patients to the general population, the Alsbach birth cohort data, and also to a comparison group. And we found that if you were in the neurodivergent group, you were 4.5 times more likely to have hypermobility than the general population. And that odd was higher in females compared to males. And if you're in the neurodivergent group, you had significantly greater symptoms of abnormalities of the autonomic nervous system. This is the orthostatic intolerance score, and musculoskeletal pain than the comparison group. And what we found, and this is just to show you here the really high rates of hypermobility according to a particular measure, nearly 80% in ADHD and autism are females meeting this, having generalized joint hypermobility. And you can see that the symptoms of orthostatic intolerance track with the number of hypermobile joints, as do the musculoskeletal symptoms. And when we put this all together, this is a mathematical thing called structural equation modeling, where we try and find out what are predictors of phenomenon. Does something in fact link or explain 2 linked variables, or does it alter its relationship? So what we found was that being neurodivergent was associated with more physical health symptoms, okay? But both of those were also associated with hypermobility. And if we put it into a model, the relationship between neurodivergence and physical health symptoms is in fact explained by the presence of hypermobility. So what does this mean? I think we need to think about hypermobility in neurodivergence much more, and all of the associated mental and physical health co-occurrences. And we need to think about neurodivergence when we're seeing hypermobile people. So, you know, across the board. And I have a couple of videos and things, and people sometimes write to me, and someone said, oh, you're always talking about the importance of screening. Screening's all right, but we need to really make sure that we think, are our services, are our strategies, are our hospitals, schools, are they neurodivergent friendly? Are they friendly for people with physical health issues? Are they accessible? And that is a piece of work in itself. And then really what we're trying to work out is what is the neurobiology of co-occurrence, and how might this link to emotion regulation? So, oh, sorry, this is just the same slide. I don't know how it ended up there twice. So I want to give you a little tidbit of data. This is not to be shared, please. Where we look to see the number, you know, I showed you these diagnostic criteria. Well, we're not focusing on the number of joints, though the pattern is the same with the number of joints. What we're focusing on is the degree of connective tissue involvement. So the number of hernias, prolapses, the presence of soft skin, arachnodactyly, all of those things. So the greater the connective tissue involvement, the higher your autism characteristics on the RADS are, particularly in the sensory motor domain. And so I think that processes affecting neurodevelopment, including the development of the sensory nervous system, are possibly being impacted by the concurrent development of the extracellular matrix and the connective tissue system. And this is something that we really need to do both basic science on and other more look into in other ways. So just as another a brief foray, seems slightly unrelated, but an awful lot of the people I see in our neurodevelopmental service, they experience significant pain. These are late diagnosed adults. They experience significant pain. They experience significant fatigue. They may have long COVID. And we have done some work linking explicitly hypermobility to fibromyalgia and ME/CFS, and found that hypermobility features predict pain and fatigue symptoms. And that we did a complicated experimental medicine study where we put people with ME/CFS and fibromyalgia on a tilt table to induce autonomic symptoms and gave them a typhoid vaccinations and mild inflammatory challenge. And we find that joint hypermobility explained why people with fibromyalgia and ME/CFS experienced autonomic induced pain, and low levels of inflammation explain whilst they experienced inflammation, autonomic induced fatigue. And we found exactly the same things with the inflammatory challenge. So that's veered away slightly from neurodivergence, but I think it's really important that we see our patients and that we upskill doctors and the community to think, what about all of these other co-occurring conditions that are going on? Chronic pain, chronic fatigue, gut issues, autonomic issues, allergy issues, skin issues, because brain fog, because these all, there is no health without mental health or physical health. We need all of the things to be best managed and supported all of the time. Okay, and then I haven't probably got much longer left. I wanted to, I think this is quite disruptive, this piece of work, in terms of thinking how we think in psychiatry. I was looking into some data, and we where I work, we're quite keen on these ideas of predictive coding and Bayesian models of free energy in the brain and how this leads to mental or neuroscience phenomena. And I wondered, and a lot of this is to do with mismatch between what you expected to happen and what actually happened. And we know that hypermobile neurodivergent people are more likely to experience dyspraxia. And I wondered whether this uncertainty about where you are in space, can this actually affect your emotions as well as your body? So what we found was we looked into it, and hypermobility seemed to predict emotion regulation issues. And this was explained by your hypo and hyper proprioceptive sensitivities. We also found that neurodivergence was associated with emotional regulation issues, and that this was linked through proprioception. Surprise, this uncertainty about where you are in your body. And then we put this model together. And so if you're a neurodivergent, emotion regulation is influenced through the degree of uncertainty about where your body is in space, but only in the presence of hypermobility. And I wonder, this really makes us think, what about our options for managing distress? Are they always about talking? Would sensory options, would exercise and proprioceptive options, could these help neurodivergent people in crisis or experiencing distress. So watch this space. Why? And then just finally, a little plug for our clinic. Why is it important to think both body and brain? Well, there's this very Embracing Complexity, who are a coalition of a broad range of neurodevelopmental charities, felt that the treatment of mental or physical health symptoms was worse. They did a massive survey because they were neurodivergent. This speaks to Mary and Seb's work about barriers. And then we did our own work and we spoke to people, and we, just as Connor was saying about how long it can take for diagnoses, that people with both developmental issues and physical health issues and mental health issues, they struggle for years to get an assessment and diagnosis for both mental and physical health problems. They feel a strong sense of being dismissed, misbelieved, overlooked when interacting with professionals and institutions. And they repeatedly encounter poor understanding and few or no adjustments for their needs within healthcare and education settings. And in fact, I forgot to put in a little slide. There's a paper released just recently about, for people with EDS, so that's one form of symptomatic hypermobility, essentially the trauma that navigating the medical system has generated, and we must bear this in mind. So implications for the future. Think brain body, think accessibility, think outside the box, and look out for our upcoming studies and our neurodivergent brain body clinic. So for people who are under the Sussex Neurodevelopmental Service, we are offering consultation and interventions around physical health issues, particularly pain, fatigue, and autonomic symptoms. I may have actually whizzed through what I was supposed to do, I'm not sure. Thank you so much for all the participants who have taken part in our research, all of the funders, my amazing colleagues, and please do get in touch, find out more. I have several podcasts, YouTube videos, and please follow me on Twitter, and I have some infographics and stuff on Instagram. So I shall stop now.
Yeah, thank you very much, Jessica. We are over to Q&A for today. Right, so we have a question from Nicole, and he says, is sciatica I get in my legs sometimes related to my autism, and is osteoporosis is also related to autism as well, and do they have any connection with hypermobility?
I missed the first one. So osteoporosis, what was the other condition?
Sciatica.
Sciatica and osteoporosis. I think there is definitely a connection between hypermobility and osteoporosis. I haven't heard of one of sciatica, but I think it's really important to think about these things. When we published the paper, Neurodivergence links autism to dysautonomia and pain, people actually contacted me on Twitter and said, but autistic people don't feel pain. And that is a myth that really needs to be busted. And I think Mary and Seb's article suggests that, you know, their people often have adverse outcomes, and maybe interoceptive stuff, processing pain in a different way, maybe leaving things until they're late. But getting a better grip on pain is so important for everyone.
Okay, we have a next question. Is hypermobility more common in girls and women than in boys and men?
Well, this is interesting. So yes, the way we measure it, it is reportedly more common in women than men. And we think that's because of the influence on hormones, on hypermobile, on joints. So in the Alspat birth cohort, 30% of of teenage girls were hypermobile compared to 10% of teenage boys. But I think men, often hypermobility is in features that aren't necessarily in the diagnostic criteria. It's slightly different. I seem to think there's a lot more of this long, thin fingers in men that goes with the soft tissue things rather than the prominently hypermobile joints. But if you do the full thing, you will find men are hypermobile too.
All right. Well, we have a next question from Shamil, and question is it persons with hypermobility can be integrated in EOCs demand physical efforts?
Integrated in, sorry, I didn't hear integrated in what physical effort?
Integrated in EOCs, EORKS.
EORKS. I'm afraid I don't know what that word means.
All right.
Interested in EORKS demand efforts. I'm really sorry, I don't know. I'm seeing it in the chat.
Shabir, can you please explain it a bit further so we can answer? All right. The next question is from Anonymous. Any work being done to pick up on non-bites and joints, that is proximal rather than distal joints?
Absolutely. So what I meant to say is that there's so many joints that are missed by the Baton scale. You know, the hips, shoulders, ankles, they will dislocate. So colleagues at UCL, Jane Simmons' work, they are working on a extended upper and lower limb assessment for hypermobility. But I think that the important thing is even if it isn't captured well by the Baton scale and you have hypermobile joints and other connective tissue features, you proceed with the diagnosis, the assumption of a hypermobility spectrum disorder.
All right. So question from Nicole is there any research about menstrual cycle and hypermobility?
Sorry.
Yeah. Does menstrual pain and that premenstrual dysphoria and side joint pain?
Oh, I think, well, certainly, as far as I'm aware, there's very limited actual research there, but in terms of our clinical experience, oh, it's huge. People's kind of orthostatic intolerant symptoms, pain, they worsen according to the menstrual cycle, ADHD symptoms, even some autistic characteristics can be impacted, but you know, sensory sensitivities and things can all be impacted by the menstrual cycle. I think this is another topic where so much more work needs to be done.
All right. And is there a link to non-drug hypermobility anxiety treatment, which you have mentioned? Oh
yes, that was a clinical trial. It isn't currently available as a, you know, you can't go and see a therapist and ask for it. But in July, we are starting another much larger clinical trial of it in IAPT for anyone with anxiety. So watch this space, and part of that grant, it's an MRC grant, is to marketize, it sounds like a terrible word, but basically set this up so that it could be incorporated into the NHS. But it's a brain body therapy rather than a wholly talking therapy. Do you see what I mean? All right. So the paper about the results, we're just finishing up the follow-up, the year follow-up now, should be coming out in the next couple of months. We have another question about correlation between autism, ADHD, and Lewy body dementia. Oh, is it connected with? Well, I think there's emerging work thinking, just putting its toes in the water about autism and ADHD and dementia, just really starting to think, because obviously so many people who are at the age of being diagnosed now with dementia or Lewy body dementia would not have likely been picked up as autistic or having ADHD as children. And but they may have autistic or ADHD grandchildren, possibly. But if you think about ADHD and dopamine, and I'm not going to go into huge detail, but dopamine is really important in the basal ganglia, which is where Lewy body dementia is going on. And we were just having a clinical conundrum in our clinic, which we haven't resolved, is we've diagnosed someone with Lewy body dementia with ADHD, managed to get phenomenal collateral. And it is quite clear that the person did have childhood ADHD, but the question is how to manage that. It's going to need some real thinking.
All right. Okay. So how much weight is given to the physical aspects linked to ASD in current diagnostic systems?
I think
diagnostic assessments.
Well, I can only speak for our own service. I think in general, probably there will be, people ask about physical health problems as part of the history. In terms of actually doing hypermobility assessments, I suspect it's a select few who have an interest in it. I mean, it's routinely done in our clinic, but as I say, we have, that's where this work was published in, and we've had an interest in it since 2009. So but maybe one day it will be part of part of the clinic, or at least just the 5-item questionnaire, which doesn't need any physical examination.
All right. Can we trace this connection of the autonomous system, neurodivergence, joint hypermobility down to a more biological link, like the connective tissue influence or something at a cellular level?
Oh, interesting. I suspect it is at a cellular level within the connective tissue. But also how the connective tissue responds to hormonal influences, to inflammatory influences. We have, my students just finished doing some amazing gene expression analyses, which I obviously we don't have time to go into now, but I think it's a number of interplaying factors, and not all hypermobile people are neurodivergent, and not all neurodivergent people are hypermobile. There is some kind of interesting thing. You have one thing in the mix and something else in the mix, and this can lead to this combination. So we will I hope that within the next 10 to 15 years, this type of thinking will be more commonplace, and we'll really be thinking about it a lot more and have understood a lot more.
Right. So is there any connection between hypermobility, POTS, and ASD?
Oh, yes. So I think I mentioned there is, we know that hypermobility is more common. POTS and hypermobility go hand in hand, that ASD or autism are related to, often seen in hypermobility. So the maths would suggest that if you are hypermobile or autistic or both, or you are more likely to have POTS. And what I was talking about in terms of the orthostatic intolerance symptoms, that was symptoms of POTS. What there was for a while, there was an interest in a gene, the norepinephrine transporter gene, that seemed to have a similar variant in both POTS and ADHD. But I think the link, as the paper suggested, the link to POTS and ADHD and autism is through connective tissue and hypermobility.
Okay, great. So another question from Mimi. Do you happen to know what kind of open questions from basic science would be relevant to understand the connection of the autonomic nervous system and connective tissue, extracellular matrix stuff?
I think how the extracellular matrix reacts, in terms of autoimmunity leading to small fiber neuropathy, I think that would be a really interesting question for postural tachycardia. But I think, I'm sorry, thinking about basic science, there's some really, every scientist needs an animal model, don't they? And there's really interesting work about joint hypermobility in dogs, and hypermobile dogs being more likely to experience thunderclap phobia, which what a model for anxiety. And then dogs with hypermobility being more excitable, even if they are like trained, basically displaying an ADHD phenotype.
All right. So there's another question. Have you included people under ED diagnosis within this? My daughter has EEC syndrome and possibly autistic in this. Okay, can I repeat the question?
Yes, please. Sorry.
Have you included people under ED diagnosis within this? My daughter has EEC syndrome and possible autistic. I'm very interested in this.
ED diagnosis? You mean eating disorders?
I think it's about like EEC syndrome.
I don't know EEC syndrome. Let me. It's not something that I am familiar with. Let me just have a quick look. EEC syndrome.
Yeah.
Ah, I found it. Genetic developmental disorder, distinctly featuring ectrodactyly, ectodermal dysplasia and facial clefts. I'm afraid it's not something that I am familiar with. I would have to have a think.
Okay. All right. The next question is there a link between hypermobility and sclerosis?
Psoriasis?
Sclerosis, I think they have mentioned. Is there any link between hypermobility and sclerosis?
Sclerosis is in multiple sclerosis, or sclerosis?
It's only sclerosis.
There was a paper published a couple of days ago about a possible link between hypermobility and multiple sclerosis.
Okay.
I think sclerosis is a broad term. We'd need to know exactly what
Spinal stenosis.
Stenosis, spinal stenosis.
Oh, they mentioned like sclerosis again. Anyways. So, okay. All right, Jessica, thank you very much for time. We are for the excellent presentation and a deep insight toward hypermobility and how neurodivergent people come across with these kind of problems and how they misdiagnosed with other mental health issues. We definitely appreciate this, and those questions which are left in our Q&A box, we definitely like to answer them later. Thank you very much for your time and your